You're listening to the lecture on management of patients with intestinal and rectal disorders. By the end of this lecture, you should be able to describe the pathophysiology, clinical manifestations, and management of patients with constipation, diarrhea, fecal incontinence, and irritable bowel syndrome. Describe the pathophysiology, clinical manifestations, and management of patients with celiac disease. Discuss the nursing management of patients with appendicitis, diverticular disease, and intestinal obstruction. Compare Crohn's disease and ulcerative colitis. Use the nursing process as a framework for care of a patient with inflammatory bowel disease. Identify the responsibilities of the nurse in meeting the needs of the patient with an intestinal diversion. And explain the nursing management of patients with colorectal cancer and anorectal disorders. There are three classes of constipation. There's functional, which involves normal transit mechanisms of mucosal transport. Treatment generally is just increasing fiber and fluids in their diet. Slow transit, which is caused by disorders of motor function of the colon, and defecatory disorders, which are caused by dysfunctional motor coordination between the pelvic floor and the sphincter. Signs and symptoms to assess for with constipation: fewer than 3 bowel movements per week, abdominal distension, complaints of pain and bloating. Patients will say that they have a sensation of incomplete evacuation, straining whenever they try to have a bowel movement, and whenever they do have a bowel movement, the fecal matter is small in volume, and it's usually hard and dry. If the need for further testing is warranted, then they will go ahead and do further diagnostic tests, but this is generally only if it's severe chronic constipation and it has other complications. Straining can result in Valsalva maneuver. This increases the arterial pressure, impeding the flow of the venous blood into the chest. This can cause the atria and ventricles to receive less blood, which leads to less blood being ejected by the ventricle. This will decrease the cardiac output and can cause orthostasis, dizziness, as well as syncope. Treatment for constipation includes identifying and resolving the underlying causes, as well as patient education. Patients need to try bowel retraining, and they should sit on their toilet daily after a meal, preferably breakfast, to establish a bowel pattern. Increasing fiber and fluid intake is also encouraged. Laxatives are not recommended, especially for routine use, because the patient body can build up a tolerance and it will decrease their effectiveness for when they really need it. Exercise can also help quite a bit. Diarrhea, acute and persistent, are classified as either non-inflammatory or inflammatory. Chronic can be classified as well as secretory, osmotic, malabsorptive, infectious, or exudative. The nurses need to assess for the following signs and symptoms whenever you do have a patient who complains of diarrhea. Look for increased frequency and fluid content of the stools. So look at the consistency of the stools. Assess for abdominal cramping, distension, borborygmus, anorexia or weight loss, as well as complaints of thirst. Assess for painful spasmodic contractions and pain, cramping in the abdominal area. Assess for tenesmus, which is ineffective, painful straining whenever you have a strong urge to push but nothing comes out. And this generally happens because you have so much stool that comes out that's evacuated that there's just nothing left. Diagnosis, they're going to do a CBC and chemistries or urinalysis. They're also going to be doing stool examination to see if they can find the cause. They can do an endoscopy or barium enema as well, and that's to find out the cause so that they can treat it. The most common complication of diarrhea is dehydration. Dehydration, along with hypokalemia, can cause cardiac dysrhythmias, and so both need to be monitored carefully. Loss of bicarbonate can also happen if you have severe diarrhea, and that will lead to metabolic acidosis. As far as patient learning needs, treatment is generally controlling the symptoms and preventing complications. Identifying and eliminating, treating the cause will also help, and that's something generally the physician will be in charge of. As a nurse, the patient will be prescribed medications, and so you will need to educate on those medications. They can get probiotics, antidiarrheal agents, anti-inflammatory agents, when to take them, how to take them, side effects of taking them are also important, and they should be drinking a sufficient amount of water to replace all of the fluid that they're losing. They should limit foods in bulk, increase their fluid intake, and they should avoid anything that will be a natural laxative. So they need to avoid caffeine, avoid alcohol, avoid dairy, avoid fatty foods, because that can help, that can irritate the bowel as well. Patients can present with minor soiling as far as fecal incontinence to complete loss of control of their bowel. So it can be one end of the spectrum to the other. They can complain about urgency, which can lead to soiling. They can be impacted, which leads to loose stool that just seeps around the impaction and causes incontinence as well. It can also be behavioral, and that needs to be looked at and addressed if it's possible to address it. Just depends on cognitive status. Treatment, we're going to treat the underlying cause, so identify and treat the cause. Make sure that the patient can perform proper skin care. You need to perform proper skin care if they cannot. And then also assess the skin every shift, because stool is extremely acidic and they can get breakdown pretty quickly. They can have fiber supplements that sometimes helps with bulking up the stool. You can give loperamide, which is an antidiarrheal medication, 30 minutes prior to the meals. That can help some patients who have loose stool that leads to incontinence. External devices can also be used if the stool's loose, but those are generally short term. Irritable bowel syndrome, or IBS, is a chronic functional disorder characterized by recurrent abdominal pain associated with disordered bowel movements. So they can have diarrhea, or they can have constipation, or they can go back and forth and have both. It's thought that genetics, environmental factors, and psychosocial factors all play a part in IBS. Diagnosis is generally made by ruling out other conditions or disorders that could cause the constipation or diarrhea. Diagnostic criteria include recurrent abdominal pain for at least 1 day weekly, as well as 2 or more of the following: abdominal pain with defecation, abdominal pain associated with change in frequency of the stool, and abdominal pain associated with change in the form and or appearance of the stool. Treatment includes relieving the abdominal pain and then controlling the diarrhea or the constipation. Patients will be taught stress reduction strategies. They're instructed to regularly exercise. Sorry about that. Get adequate sleep. They can add soluble fiber to the diet, and that can help with the symptoms as well. Generally, they go through a restricted diet to see if they can find causes, if any of the foods are the cause of the IBS. And so they'll slowly reintroduce one food at a time, and they'll usually have that food, and that's the only new food they'll have for several days to see if it's causing it. They can also be given antidiarrheal agents and medications that will slow the colonic motility, and that will help if they have diarrhea, not the constipation. Obviously, you don't want to slow things down more. Malabsorption can be caused by mucosal disorders like celiac disease, Crohn's disease, or radiation enteritis. Luminal disorders such as bile acid deficiency or Zollinger-Ellison syndrome. Pancreatic insufficiency, chronic pancreatitis, and small bowel bacterial growth. And then lymphatic obstructions usually are from surgical trauma or neoplasms. Patients will have loose, foul-smelling stool. Their stool will be grayish, and it'll be higher in fat content, so you can definitely tell. They'll also have vitamin and mineral deficiencies and need supplementation. They'll also have weight loss. There are multiple diagnostic findings that you can do, and it just depends on the symptoms, the patient's H&P that they present with, and what the doctor feels is necessary. As far as patient learning needs, patients will need a supplemental replacements. You'll teach them about diet therapy, find out what the triggers are so that you can eliminate the triggers. They can take probiotics, and they might need to kind of play around with the probiotics that help. Some of them can cause bloating or gas, while others they can tolerate more. You'll monitor fluid and electrolyte imbalance, and then monitor because of the vitamin deficiency, monitor for osteoporosis. Celiac disease is an autoimmune immune response that leads to inflammation in the proximal portion of the small intestine. The mucosa will eventually become denuded and it will no longer function, especially whenever they have these recurrent episodes of inflammation. This leads to the inability of the small intestine to absorb micro and macronutrients, and then they can become malnourished and have vitamin deficiencies. Non-GI symptoms, the GI symptoms are there, but non-GI symptoms generally result in malabsorption, and so they'll have yellowing of the teeth, anemia. They can have headache, dermatitis, hermatiformis, which is clusters of red macules that develop. They turn into itchy papules and vesicles, generally on the forearms, elbows, knees, face, and buttocks, and if they're scratched, they can become infected. Treatment, a gluten-free diet, so avoid anything that has gluten in it, which is wheat, barley, bran, spelt, rye, pretty much anything that's good for pasta. And then they do have gluten-free pastas now. They have gluten-free everything, gluten-free bagels, gluten-free crackers. The only thing that you have to watch for and patients need to be aware of is that there can be gluten contamination if they're in the same plant that makes food that has gluten in it. They can get contamination through the equipment that's being used. It can be contamination during packaging. Whenever you go to restaurants, there can be cross-contamination as well. So they need to really be aware of that, especially if they have a severe gluten allergy and a severe reaction. Peritonitis is inflammation of the peritoneum. It can be primary, secondary, or tertiary. Clinical manifestations are basically the same no matter what the classification is. Treatment is generally a fluid, colloid replacement, electrolyte replacements. Patients will generally get isotonic IV fluids, and they'll get analgesics for pain. They can get antiemetics if they complain of nausea and vomiting. And then find out what the underlying cause is and treat the cause and make sure that they do not become septic. So you'll be monitoring for septic shock. Appendicitis. The appendix is attached to the cecum just below the ileocecal valve. Diagnosis of appendicitis is based on H&P, elevated white count, and elevated CRP. They can do an ultrasound or CAT scan, and it will show that the appendix is enlarged. Treatment does need to be done pretty quickly. Complications, you can get gangrene and perforation of the appendix, and that can lead to peritonitis. Perforation can occur as early as 6 hours after onset of pain. So they will go into surgery as soon as they possibly can. And as far as nursing management pre-op, you're going to control the pain, nausea, and vomiting. Watch for signs of peritonitis and septic shock. Afterwards, it's the same as anyone who has post-op surgery. Diverticular disease, weakened wall muscles can lead to perforation, abscesses, bleeding, as well as peritonitis. Signs and symptoms of diverticulosis, generally they're asymptomatic with diverticulosis. They can sometimes complain of minor symptoms. Diverticulitis, on the other hand, is different, and it's an inflammation of the weakened wall that protrudes out. They'll complain of pain to the left lower quadrant generally, They'll have a change in bowel habits. Usually it's constipation. They'll also have nausea, vomiting, fever. Whenever you look at their labs, you'll see leukocytosis. Treatment will depend on the presence of complications. It can be as simple as making them NPO, putting them on bowel rest, and giving them medications and being treated at home, or they can be hospitalized. They can be placed NPO, given IV fluids and NG to suction, and longer bowel rest. Antibiotic therapy can be initiated. Opioid analgesics is usually what they're given for their pain control because the pain can be pretty severe. Once the pain is gone, and that's not controlled with analgesics, but gone off of the analgesics, they will slowly be reintroduced to oral intake, and it will start with a clear liquid diet, then full, then soft, and they'll stay on a low fiber diet usually for quite a while. If there are complications, then they do need surgical management. So as far as nursing management, if they do have diverticulitis, encourage fluids once they're not NPO anymore. Make sure that they have cooked vegetables so it's easier for them to pass initially. They should be on some sort of an exercise program that helps with the peristalsis. And they can be given stool softeners and laxatives as well. That'll help keep the stool soft so it won't irritate the diverticulosis. Intestinal obstructions, they can be partial, they can also be complete. Most occur in the small intestine, but they can occur in the large intestine as well. Adhesions are the most common cause of a small bowel obstruction. For large bowel obstructions, the most common cause is cancer. Surgery will depend on the cause of the obstruction. So if there's a hernia or adhesion, then they'll do laparoscopic surgery. And laparoscopic is becoming more common than traditional. They will also try bowel rest. If they think it's just an impaction that's causing the obstruction, they might do an enema. So it just depends on what the cause is and if there's any complications with it. As far as nursing management, you're going to monitor for signs and symptoms of perforation. If surgery is not warranted, then follow the proper interventions for pain control. And if they have an NG tube, monitor placement and function of the NG tube, monitor output, that sort of thing. You'll definitely want to monitor intake and output to make sure that they don't have any kind of fluid electrolyte imbalance, dehydration going on. And then you'll check their labs for electrolytes. Inflammatory bowel disease, there's Crohn's disease and ulcerative colitis, and they are different. They're the most common types of inflammatory bowel disease, and you can see this comes from your book. Treatment for both is going to be corticosteroids that helps with the inflammation. Immunomodulators, antibiotics can be given. But what you need to look for, pathology is important. Clinical manifestations are going to be different. So make sure you understand the difference between the clinical manifestations, and then systemic complications are also quite different. So understand the difference between those two. As far as assessment of a patient who has inflammatory bowel disease, make sure you get a good history. You want a health history as well as familial history. Ask them about onset, duration, characteristics of pain, diarrhea. Sorry. What does their stool look like? Do they have any unexplained weight loss? How's their appetite? Do they notice any bleeding? If they have vomiting, what does their emesis look like? Yeah, ask all those questions. Ask them about their diet. Do dietary recall. Do they consume alcohol, caffeine, and nicotine? Because that can aggravate it. And how often are they going? Do they have days where they skip? Sometimes people will have multiple stools and then they'll go days without anything, and then they'll have multiple stools. So just kind of figure out if they have some kind of a pattern, even if it seems like a sporadic kind of a pattern. Do a good abdominal assessment. Make sure you look, listen, and then feel. You're going to look for complications, especially if they're admitted, because they could be dehydrated, they could have low potassium levels. So monitor for changes in level of consciousness. You'll do an EKG Usually they're on a continuous ECG just for monitoring. Make sure they don't have any kind of dysrhythmias. That is because of low potassium, needs to be reported immediately. Monitor for signs and symptoms of hypovolemic shock. You want to look at their coagulation levels, make sure that those are okay. Make sure that they don't have any symptoms of an obstruction or a toxic megacolon. With the megacolon, they'll have abdominal distension, decreased or completely absent bowel sounds. They'll have change in mental status. They usually have tachycardia, fever, and hypotension as well. And that's because they're going into shock. You can give them loperamide 30 minutes prior to meals, especially if eating causes them to have diarrhea. Make sure that they have easy access to the bathroom. They might even need a bedside commode. And make sure that they take in enough fluids if they're not in PO. Prevent skin breakdown, especially if they're having multiple stools and if they're having incontinence. You might want to give them pads. Make sure they change their pads every time they go to the bathroom. They might need some kind of barrier ointment. Help them with self-image. They might have self-image issues related to the smell because it can be a pretty strong odor whenever they have loose stools. And then provide them with education on everything, what's going on with their body. It's a long-term disease. Find out if you can find if there's triggers and teach them about that. Teach them about doing a dietary journal, and they might notice that they have some kind of a pattern with certain foods in their bowel movements. Talk to them about nutrition and diet, the purpose of their medications, when to take them, when to call the doctor. They can look and join, there's foundations out there, there's organizations, there's support groups locally and nationally if they need to have an ileostomy placed because they might need to have part of their bowel removed from the Crohn's or ulcerative colitis. You'll want to teach them about the diversionary device they have as well, which segues into the intestinal diversions. A patient can have an ileostomy or a colostomy. Ileostomy is an opening of the ileum or small intestine up through the abdomen, and then the colostomy is an opening into the colon and the colon is actually pulled out and flipped inside out and then sutured around onto the abdominal wall. If it is not an emergency surgery, then they will have wound ostomy and continence nurses and the surgeon find the best placement. They'll have the patient change positions, lay, sit, stand, to see where the best place for the appliance will be. If it's an emergency situation, they just do the best that they can. Patients, if they do have a diversionary device, then they will need to avoid foods that are cellulose-based, which would be like nuts and seeds. And then you'll want to talk to them about diet if they're going out to eat, how they can reduce gas in their appliance. Talk to them about the best time to change it. Usually it's first thing in the morning before they eat. Once they start eating, then peristalsis will pick up and they have a greater chance of having stool come out of their device when they're trying to change it. You'll want to make sure that they have good pain control. If they have an ileostomy, they need to be educated on signs and symptoms of dehydration, low potassium, fluid and electrolyte imbalance. They need to monitor their intake and output. Ileostomies can lose up to 2,000 mils per day of loose stool. If they're not taking in enough fluids, they're not supplementing, then they can get dehydrated or hypovolemic. They need to be taught about the stoma, what to look for whenever they are doing their maintenance, their daily care, emptying out the appliance, and then whenever they're removing the old appliance, putting a new appliance on, looking at the stoma as well as the peristomal skin. The stoma needs to be a beautiful rosy red color. If it's light pink, grayish white, black, brown, then they need to notify the physician right away. If it starts to retract, they need to let the physician know. The peristomal skin should not be showing. You only want an eighth or less of the peristomal skin showing whenever you have an appliance. The skin needs to be kept clean and dry. Watch for leakage under the appliance because that can cause erosion of the skin. And then the appliances, one-piece appliances usually get changed every 3 to 5 days. Two-piece appliances can usually be kept on for up to a week, but the patient has to decide what's best for their body, as far as the shape of their body, where their stoma's at, how much stool they produce, and how often they want to have it changed. There's just a bunch of different things that go into it. You don't want to keep it on longer than it should be on, though, because you can get that seepage underneath. Like, you can still have the appliance intact and it'll actually, the stool will seep underneath, and then that causes wounds, which makes it more difficult to try and keep an appliance on. Colorectal cancer is the third most common cancer in the United States. Manifestations include change in bowel habits, blood in the stool, so they might have the tarry black stool. They might see actually frank red bleeding. They can do an occult blood test or stool test to see if there's blood in the stool. They can have the same symptoms as an obstruction. They can have pain, and they might have more rectal type pain. They can also have abdominal pain. They can also feel like they're not able to completely evacuate their bowels. Screenings generally start at age 50, and colonoscopies are done every 10 years. If there's a familial history, then they'll start it earlier. CEA is a tumor marker that can be tested for. However, the test is not always reliable, so it does show both false negatives and false positives. So it can be used as a screening in conjunction with other things. Treatment depends on the stage of the colon cancer. Treatment can consist of surgery, it can be supportive therapy, adjuvant therapy. Staging of cancer can only be done after surgical incision, so they'll actually have to go in and remove the mass. They'll try and remove all of the mass if they can, and then some of the surrounding tissue, lymph nodes as well, and then they'll send those off for testing. Colostomies can be placed depending on how what part of the colon, if it's a colostomy, needs to be removed. Ileostomy, its placement just depends on partly the patient themselves and their own body, and then what needs to be removed as far as the small intestine. If you have a patient who has stage 2 and stage 3, they might need chemotherapy in addition to surgical intervention. Stage 2, they might just need the surgical intervention. Stage 4, they can get chemoradiation in addition to surgical intervention. They also might have to go palliative. It just depends on what's going on with the patient. As far as assessment of patients with cancer, look at the stool, look at the color, odor, consistency. Do you see a presence of blood or mucus in the stool? And you would report that to the physician recorded in the documentation. Look at their fat intake, look at their fiber intake. Are they consuming alcohol? Do they have a history of consuming alcohol? If so, how much were they drinking? When did they stop? How much are they drinking now? History of smoking or current smoking, and then do they have any unintentional weight loss? Or is it intentional? You need to make sure you know either way. But unintentional weight loss is also another sign. Interventions, if they're going to have surgery, prep them for surgery. You'll do all the education. Make sure they have the informed consent beforehand. Answer any questions that they might have. If they think that they might have cancer, then they're going to need a lot of emotional, psychosocial support. And you can have family and friends come in. You can have a chaplain come in. If they have someone at their church that they want to talk to, they can come in. But give them the resources that they need. If they're going to have to have a colostomy, then you need to provide them education on that. The wound ostomy and continence nurse will meet with them before the surgery and then follow them after the surgery. But you still need to talk to them about it as well. Talk to them about any and everything. If they're really quiet, then, speak in general terms. People who get colostomies usually are concerned about body odor, or that people can smell, or that they can tell that they have one, or, they're concerned about if their spouse will find them attractive anymore and still want to have sexual relationship. There are different support groups out there as well that can help them. As far as potential complications, just look for signs and symptoms of any kind of complications, and you need to let the physician know right away so that they can have prompt treatment and intervention. Anorectal conditions, proctitis is an inflammation of the mucus of the rectum, secondary to usually a sexually transmitted infection, but it can be non-sexually transmitted infection as well. It's just generally caused by STIs. It can be also caused by inflammatory bowel disease or radiation. Diagnosis, the patient will have a sigmoidoscopy and biopsies will be taken and sent to the lab. And then the patients will be given antivirals if the infection's viral, antibiotics if it's a bacterial infection. Anorectal abscesses are caused by obstruction of the anal gland, and that results in retrograde infection. Patients with Crohn's disease and HIV are most prone to anorectal abscesses. Signs and symptoms include a discomfort or itching or dull perianal pain. The pain can be increased with defecation, and they'll go in and do an I&D to get rid of that abscess. An anal fistula is a tiny tubular fibrous tract. It extends into the anal canal from an opening in the perianal skin. It's usually a result from an abscess, and the abscess is just trying to find a place to drain. Signs and symptoms are purulent drainage or stool that leaks from the opening of the fistula, and surgery is generally the treatment that's done. Anal fissures are longitudinal tears or ulcerations in the lining of the anal canal. This is generally caused by trauma, either from passing large-stride stool or from inserting something into the rectum in the anal canal. Signs and symptoms, the patient will complain of painful defecation, burning. They'll also notice frank red blood or bleeding through the anus. Conservative measures usually for treatment, fiber supplements, helping with the constipation, stool softeners, bulking agents, changing their diet, increasing fluid intake. They can also do sitz baths, which will help with the pain. Pilonidal cysts or sinuses, local trauma can cause penetration of the hairs into the epithelium and the subcutaneous tissue, and then they just continue to regenerate and they get the sinus tract or the cyst. Patients complain of pain, they'll also complain of drainage, and surgical intervention is the treatment of choice, and so they'll go do an I&D, and then it'll be followed up by wound care. As far as assessment, just like you would anyone else, you're going to get an H&P, you're going to do an assessment focused on what their complaints are, ask about elimination patterns, dietary patterns, alcohol, smoking, what do they do? Do they have a sedentary job? Do they have an occupation? And that puts them at risk for being around carcinogenic materials. Look at the area that they're complaining about. You'll do an abdominal assessment. Remember, look, listen, and feel. Look at their stool. You want to make sure the perianal area is kept as clean as possible. If they complain of itching, burning, pain, they shouldn't rub the area because it can make things worse. They might have painful spasms of the sphincter and perianal muscles if they have surgery. So the first 24 hours post-op, they can complain of a lot of pain, and they'll have cramping or spasm type pains. Ice will help. After the first 24 to 48 hours, they can do analgesic ointments. That can help. Warm compresses and sitz baths help, and they can do the sitz baths 3 to 4 times a day.